Jaya Chandrasekhar, and on behalf of Global CVCT, I'm very pleased to be sitting this evening with Professor Koenig to discuss the key findings from the LATITUDE TIMI 60 study discussed at ACC 2016. Welcome, Professor Koenig.
Thank you.
So if you could go through the study design and really the main findings of the study for our viewers this evening, that would be great.
Well, in the LATITUDE TIMI 60, the investigator would target a p38 MAP kinase, which is an intracellular enzyme that is expressed in macrophages, in monocytes and endothelial cells, and it participates in many biological adaptive and maladaptive processes like inflammation, oxidative stress, etc. So the idea was to really, with a selective inhibitor, and losmapimod is such a selective inhibitor of p38 MAP kinase, to attenuate the inflammatory response that we see in cardiovascular disease, in particular after myocardial infarction. So there have been some preclinical and clinical studies that suggest that the application of this drug would attenuate the inflammatory response. And now this was based on an adaptive design, a trial, a phase 3 trial that would test the hypothesis whether or not the application of this drug could reduce myocardial infarction events in STEMI and non-STEMI patients.
So if I could interrupt, so what they were looking at is to even look at just plaque stabilization with this inhibitor. So plaque stabilization and therefore recurrence of events in this ACS population.
You're right. So basically the design they would use was a two-stage design, a leading cohort of 3,500 subjects, STEMI and non-STEMI, mainly non-STEMI, 75% non-STEMI. And they would give the drug as early as possible in hospital before revascularization, obviously, and then it would look into a 12-week outcome, and this was based on an estimation of 7% event rate in the placebo group and a 16% relative risk reduction. And actually what they found was a 7% event rate in the overall MI population, but unexpectedly an 8.1% event rate in the intervention group. So there was a 16% increased risk, which they didn't expect. And based on this, they did not go on for the full cohort, for the full study, which would comprise 22,000 subjects. They said there is no chance that we will come up with a positive finding. In addition to the main endpoint, which was a clinical endpoint, I said already, consisting of cardiovascular death, of myocardial infarction, and urgent revascularization, they also looked into surrogate markers, into hsCRP, a general marker of inflammation, and also a netropeptide, anti-proBNP, that is related to overload and remodeling. And what they could see was at 12 weeks, there was some kind of not only 12 weeks, but also 4 weeks, a reduction in hsCRP and also a reduction in anti-proBNP. But on the other hand, the endpoint was negative.
So that's really interesting. You know, the other thing that I looked at when they presented the results, the baseline CRP and the baseline BNP levels in both the placebo and the experimental arm were normal, within the normal range. So in these patients coming in with an ACS, there was, a non-STEMI population presenting within 24 hours of symptom onset, and the STEMI population presenting within 12 hours of symptom onset. Right. When do you expect these inflammatory markers, CRP and BNP, to go up? Is it within, in your experience, do you think this is within 48 hours, within the first week?
That's a good question. Basically, the elevation of CRP is driven by cytokines, IL-6, for example, IL-1. So usually it takes about 48 hours for the maximum of CRP. But you're right. They had included STEMIs 12 hours. After the beginning of symptoms, but you never know what has been going on before, especially particularly in the non-STEMI population, and the non-STEMI population was much larger. That was 75% of the overall population. So you're right. Basically, it needs some time to upregulate to induce the acute phase response. So that may be something to consider. However, with the anti-proBNP, I think you get a more immediate response. And if you look at the values, in the end, there was a difference of about 100 nanograms per liter or something like that in that order. So there was really a trend for a decrease in anti-proBNPs, which were not grossly abnormal, as you correctly stated.
So, we see a difference in these inflammatory markers, a difference in the CRP with this drug, a difference in the BNP. And in a phase 2 trial, they'd shown an improvement in LV systolic function, yet we don't see these, we don't see a difference in clinical outcomes. So what does that mean? What are the implications for the inflammatory processes influencing these outcomes? And what should we do in the future for trials like this?
Yeah. I think targeted inflammation is a very difficult issue because it's a very complex interplay with so many factors. So it's really very important to target the right one. And as you may recall, during the last 2 years, we had several negative examples, negative outcome studies, like those with the phospholipases, with the lipoprotein-associated phospholipase A2, the SOLID study, the stability study, and also with secretory phospholipase, which are definitely implicated in inflammatory reactions, but the selective inhibitors were not able to reduce cardiovascular events. So I think basically the message for me is, first we need to go on with studying inflammation as a potential target, because there is so much observational evidence that inflammation plays a role, but we don't know yet whether or not we really can make an impact by targeting inflammation. But we need to find the right target. So as you know, other studies are ongoing right now, like CANTOS, which look into inflammation which looks into inflammation as well, and uses an antibody against IL-1 beta, canakinumab, and we probably will have the results by early 2018. Then the third trial, also led by Paul Ridker, which applies low-dose methotrexate in a post-infarction population. And there's also a new colchicine trial, which I think is interesting because colchicine, there are really interesting data in stable patients, but also a recent paper in circulation has shown that in the setting of acute STEMI, you can reduce infarct size both as seen with MRI, late enhancement, but also with biomarkers. Right. So there is still, I think the question is not settled, and a lot has still to be done, and hopefully we find the right interventional target for this issue.
So another comment to make just around this, from an interventional perspective, in this particular study, so LATITUDE TIMI, they presented that 2/3 of the non-STEMI patients had PCI, 90% of the STEMI patients had PCI. And just as an interventionist, I'm interested in what stents they received and what kind of P2Y12 inhibitor they received, because this was not reported in the main paper. And of course, we know that with the latest generation drug-eluting stents and with potent P2Y12 agents, this can impact on recurrence of events. This can affect stent thrombosis, and those were components of the composite outcome. And so perhaps, future studies looking at these inflammatory targets also need to take that into consideration, because a lot of benefit is already derived from these things. So additional benefit from, the MAPK inhibitor may be limited or affected, influenced by this.
Could be an explanation. I think you're right. Stent thrombosis was not reported, and during this initial 12 weeks, you may have seen one. It's right. Early, and as you know, in most of the ACS trials, I think it was in the order of 1 point something percent over 6 months, or even over a year. Right. So it's a rare situation. And as you have seen from the population distribution, I think more than 2/3 would come from Europe. And Europe, in most of the centers that are doing these clinical trials, they're using the latest stent technology, even more advanced than in the US, because the approval is easier in European countries, and all of them do get dual platelet therapy. Right. So, but it is an issue. I agree.
And a final comment to make is, in this meeting, there's been discussion about vulnerable endothelium rather than vulnerable plaque. And just because a lot of our patients going into trials are on baseline statin therapy, perhaps we're not seeing so much plaque now as much as before, and maybe vulnerable plaque and plaque rupture is less of a problem, and maybe there's more plaque erosion. And so, the effect of these targeted therapies that we're talking about can be maybe different, can be affected, by this as well on a baseline level.
Yes, you're right. That's something that has been extensively discussed by, especially by Peter Lippi, for example, and there is some evidence that we're seeing more erosions and then full plaque ruptures. And in particular, I mean, you know about that shift between STEMI and non-STEMI, so we're seeing more non-STEMIs now
Exactly.
than some time before. I think that this is due to a more effective intervention, to a more effective drug therapy, preventative therapy, and maybe also earlier detection, because in Europe, a lot of centers are using high-sensitive troponin assays, so you detect ischemic events earlier, before you have the full-blown rupture.
Absolutely. No, thank you very much. Thank you for sharing your insights and your time with us this evening. Have a good evening.
Thank you. It was a pleasure.